Everybody. So my name is Chris Antenucci. I'm a physician in addiction medicine and also in family medicine. I work at MetroHealth in the Cleveland area. I take care of patients in the outpatient setting, and I also am faculty on the fellowship for the Addiction Medicine Fellowship at MetroHealth. So today's topic is going to be screening, which I have to confess, whenever I think I'm going to talk about screening, the first time I talked about screening, I was like, oh, this is kind of boring, but actually it's really exciting. It gets at issues of access and health equity and reducing disparities, because a lot of Black and Brown people don't get access to addiction care, and SBIRT is a way of addressing that and making sure that everybody who struggles with substances has access to evidence-based, high-quality care. I have no disclosures. The main goal of this session, as I said, is going to be talking about screening, but also spending some time talking about how do we talk about addiction. We touched on that a little bit last time, but we're going to dive a little deeper today in how do you have a brief intervention around substance use with your patient, and then also the referral to treatment process. And I've been doing addiction for a while, but I'm guessing there's many of you out on this call that have more expertise than I do on, these conversations. So I hope you'll all feel free to join in and share your knowledge about what works for you when you're discussing these topics. As a review from last time, substance use disorder is common. About 1 in 10 people at some point in their lives will have substance use disorder. And once you step into a medical setting, the prevalence of the likelihood of somebody having substance use disorder goes up. So it's 20% primary care, even more in the hospital, and at its highest when you're in an emergency room or an urgent care setting. So the important thing to remember is that if we aren't addressing these substance use issues, if we're not making the diagnosis, we not only lose the opportunity to get somebody treatment, but we also are, letting risky behavior progress to actual addiction and the complications and illnesses that go along with that. So it's really important to remember it's common, it's out there, and if we can make the diagnosis and talk about it, we can help change lives. Sort of putting on your public health hat for those of you that are doing like population health. When you do screening, when you're talking to patients about sort of their, ACO recommended conditions that we screen for, the way they pick those conditions is, are the conditions common? Are they treatable? And, is there a risk of progression to complications without intervention? So SUD addiction meets all those boxes. It's common, it's treatable, the diagnosis gets missed. And if the diagnosis gets missed, people progress from risky behavior to addiction, not always, but often. And then there's all sorts of illnesses and complications, including overdose deaths. And we know that treatment can save lives and works, and not always, but it can work. And it can help prevent complications. So when we talk about SBIRT, it's just a acronym for screening, brief intervention, and referral to treatment. And again, it's this sort of universal public health approach to trying to identify folks who have substance use issues. It's not done by specialists. I'm not doing SBIRT in my clinic. You all out there in either primary care or in the hospitals or in care coordination, those are the kind of settings where people can do SBIRT. They also, they've had projects where they've done SBIRT in schools and libraries and in OB/GYN clinics, emergency rooms, hospitals. So SBIRT is done in sort of the non-addiction specialty setting. And again, the goal is sort of screening with a universal tool, for identifying people and then having a conversation to try to prevent progression and get people connected to treatment. Because we do know that treatment, it's more successful if you can connect people sooner, right? So if you're in the hospital and somebody's got end-stage liver disease from 50 years of drinking, it's going to be really hard to have successful treatment for that patient versus, somebody who's younger and maybe binge drinking here and there. You're much more likely to be able to move the needle earlier in the illness. So again, not to be broken record, but SBIRT it's about universal screening. It's about avoiding bias. So you're not just having the conversation with the patient who kind of quote unquote looks like they have addiction. You're having it with everybody, and it's normalizing substance use care. It's just part of primary care. It's part of routine preventive medicine. And again, the goal is trying to identify folks, get them connected to services, help them change their behavior, and prevent progression to more serious illnesses. And also just by screening, even if a patient isn't using in that moment, you're sort of educating them about the risks and benefits for the future if they did sort of come to a point in their life where they might start using. As we talked about last week, substance use is a spectrum. Not everybody that uses has addiction. Actually, most people that use substances don't. 9 out of 10 people use substances, and it's not what we would call an addiction. And people move back and forth over this spectrum in the course of their lifetime. So lots of people don't struggle from addiction, but again, lots of people do. About 1 in 10 at some point have addiction or substance use disorder. It's common, and it's as common as other things like asthma or high blood pressure. So it's a frequently seen medical condition that we just tend to not talk about. It's kind of invisible, unfortunately. So screening helps us identify people who have risk and also people who actually have addiction. When we're talking about risk, for the way the experts define it is any kind of cigarette use, any kind of drug use could be potentially a risk. And it's not necessarily addiction, but it's something that you need to evaluate. And then when it comes to drinking, if you're a man and you're drinking more than 4 drinks a day, or if you're a woman and you're drinking, or an older person and you're drinking more than 3 drinks a day, then that's considered at-risk alcohol use. When we talk about addiction, that's another thing that's going to be identified by doing this SBIRT, by doing sort of universal sort of validated screening tools. When you identify addiction, what you're calling addiction is somebody who has this chronic disease. That's sort of the new model of how we identify a substance use disorder. And the 3 kind of buckets are: the patient has a loss of control around that substance use. They keep using even though they're having negative consequences, like maybe a car crash or a lost job. And they're having more often physiologic dependence and tolerance and withdrawal related to that substance. So for the DSM questions, like if I'm going to make the diagnosis of a use disorder, it's the same 11 questions that I ask no matter what the substance is. And I just switch the word. I'm either asking about THC or alcohol or opiates. And if they're 2 to 3 positive, then that's mild. And then, 4 to 5 is moderate, and anything more than that's severe. So that's how you diagnose a use disorder by the psychiatric manual. Again, this is a little bit of a review from session 1. We now try to think about and talk about addiction as a chronic disease. It is really a primary brain disease that can come and go. So it's a relapsing illness like lots of other illnesses like diabetes or CHF. It affects the neurons from the reward center of your brain and kind of impairs how they connect with your frontal cortex. And this slide sort of shows you, the areas where alcohol, opiates, and cocaine can all sort of affect those dopamine neurons and how those dopamine neurons reach and communicate with the frontal cortex, which is kind of your decision-making part of your brain, like your, rational part of your brain, if you want to say. Again, addiction's common. It's usually due to a combination of genetics and environment. So have you had trauma? Have you had lots of access to substances? For those of you that know about like the ACEs score, that would be another way of looking at life experiences that might predispose you to the risk of substance use struggles. Undertreated is another big message I want to hit today, because only 1 in 10 people get treatment. Again, a lot of those people tend to be upper class or white, and we really want to change that because we have good treatment and we want to make sure that everybody has access to quality care. And we want to talk about addiction in a way where we're minimizing stigma and shame and avoiding sort of old terms like abuse and addict and junkie, and trying to switch to better terms like, substance use disorder. As I mentioned, screening and getting people connected to treatment can prevent progression. Most people do not have a use disorder, but if we wait and we're just identifying and trying to intervene when people hit the top of this pyramid, where they really have addiction and a substance use disorder, that little red triangle, you're going to be missing all that whole yellow zone. You're going to be missing all those people that might be at risk. And if you're only focusing on the obvious and the late stage addiction, you're missing that opportunity to intervene. You're also possibly going to have less efficacy with your treatment, because it's, as you know, with any behavior you've ever tried to change, it's harder to change the more entrenched the behavior is. In terms of the benefits of SBIRT, it's really well documented that, especially in the primary care setting, screening is super useful. It decreases the amount of substance use. It decreases illnesses related to the substance use, like HIV and hepatitis C and infections. It decreases your likelihood of being connected to the legal system. It gives you better outcomes in terms of having a roof over your head, having a job, having your mental health be under control. So they've done lots of studies that show that there's lots of benefits to screening, talking to people, and getting them connected to treatment. Doesn't mean you're going to change everybody or get every person, successfully connected to care, but it does mean that you're definitely going to move the needle. You're going to make a difference. And screening also impacts the behavior of people working in the clinic, because if you're talking about addiction as if it's just part of normal healthcare, that affects the sort of opinions of staff and providers. It also has been shown to decrease provider prescribing behavior. So providers are less likely to prescribe opiates when their clinic is engaged in addiction screening. So what do you do once you do the screening? You are going to be, if the patient's in that sort of low risk bucket, you're going to just be sort of supporting them and encouraging them to continue their low use behavior. If they're sort of in that medium risky area, you're going to sort of work with them and have conversations with them around change talk, change behavior, and creating the goal, encouraging the goal of decreasing their use. And then if you're in sort of that severe substance use, risky, high risk dependency category, then your goal with your conversation, the brief intervention, is going to be getting them to be agreeable to refer to treatment. Does that sort of make sense? So you're screening people, and then what you do with that screening depends on the outcome of the screening. Low risk folks, it's just sort of, high five, whatever you want to call it. Medium risk folks, it's really trying to explore that issue with them. And then the higher risk folks who actually have addiction, it's going to be trying to encourage them to maybe get into a treatment program. The focus of the talk today is not nicotine. I'm assuming you guys have all had tons of discussions and education around nicotine. I have a whole separate lecture on that. If you want to have a conversation around that, I'm happy to do that. But it's just important to remember, in Ohio, about 25% of people are using nicotine. The most important thing is to ask, which most of us do. And that's a pretty accepted part of healthcare in most settings, is asking about cigarette use or vaping. And then offering treatment, whether that's medication or getting people connected to a phone coach through the Quit line, or smoking cessation classes, apps, texts. There's all sorts of stuff out there. I'm going to spend more time talking about alcohol and drugs, because that's the area where I think we fall short. in healthcare. We kind of don't do as good of a job talking about those issues comfortably. Alcohol is really the number one used substance, right? It's much more common, you know, about 46% of people are light drinkers, and then another 20% are moderate to heavy drinkers, which means you've got about 35% of people abstaining. So alcohol of all substances is the most common. The way you would do screening, if you were truly trying to do SBIRT at your site, and again, SBIRT's not like a one-person job. It's not really sort of like, oh, I'm going to do SBIRT. It's really sort of like a group decision. Like your whole team at work kind of needs to decide, this is something we want to invest time and energy in, because it does take time and energy to get it up and running. And then once you've got it up and running, it can be really not that difficult. I don't know. Is anybody here doing routine annual screening as part of their practice? I can't see hands, Darian. Is anybody? I'm guessing not. It's just, you know, I've asked around in different cities in Ohio, and I haven't had anybody say that their hospital or their clinic is doing it. Which again is kind of a shame, but I get it, because we've tried it at a few of our different sites at Metro, and we can talk more about that, but it's hard to get it up and running for lots of different reasons. If you are going to screen for alcohol, it's just a single question screener. You're trying to find, in the past year, have they had any heavy drinking days? And the definition of heavy drinking days is right there on the screen. If they've had any heavy drinking days in the past 12 months, then you're going to dive a little deeper and do something called the audit. And when we talk about a drink, not all drinks are created equal. So it depends what you're drinking and how much of it you're drinking, right? So 5 ounces of wine, 8 ounces of malt liquor, 12 ounces of beer, because they all have different alcohol contents. I'm not going to go into the audit. You can look it up. It's, you know, but just let it suffice to say it's a 10-question screener that goes after the 1-question quick screen. And then in terms of the score on the audit, if somebody's had any heavy drinking days in the past 12 months, you know, they say, yes, I did it once, then you do the audit, and then you look at the number you got on the audit, and you sort of decide, you know, are they on that red part of the pyramid, right? Did they have a really high audit score, and I'm really worried that they probably have a use disorder? Do they have a medium score on the audit? Are they kind of in that orange area? And that score on your alcohol audit assessment will then determine, like I said, whether you're just going to kind of say, awesome, keep doing what you're doing, whether you're going to say, let's take a moment and talk about that, or whether you're going to say, I think we really should, you know, explore treatment. Same with drugs.
Really
Sorry.
quick.
Yeah.
Just a quick question. Wondering if that includes the SDOH screening.
So we do social determinants of health screening at Metro. Is that what you mean? Or everybody does the SDOH screening in a little bit of a different way. And no, it's not. I mean, it's not this. It's not the audit. It's not the DAST. I would have to defer to the people at Metro who work in our population health department. But I believe it's sort of like the 1-question screener, but I don't know that it gets followed up.
Oh, sorry, go ahead, Pat.
Yeah, we do ask, I'm looking at it now. I'm a
It's
community
one of the
health worker.
questions on there.
I'm with Institute for Hope.
Yep.
So that is a question we ask, and it's like, how often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you are drinking? And how often do you have 6 or more drinks on one occasion?
Yep. Perfect. So that is the 1-question screener. And then tell me, what do you guys do with that information if they say once or twice in the past 12 months, I had more than 6 drinks?
So I just had a gentleman that's why I was late, because I was on the phone with a patient. He said he drink like monthly or less than monthly. He drank the Modelo's. I think I'm pronouncing them right. He said with them being so small, he said he have about 5 or 6 drinks, but he don't even drink every day on an occasion. It's like birthdays or things like that. He said within the last year, he only went out probably like 2 times. So I don't, it's not for me to judge and say, well, yeah, you got a drinking problem. But if he would have told me it was more than, if it was like every day he went out at least 4 to 5 times a month and that's how much he drank, I think then I would may have brought it to his attention like, hey, are you okay? Is there something going on to where you need assistance with helping you with this problem? Or tell him to talk to his primary care doctor and say, hey, see if you can speak with your primary care doctor, see if there's anything you can do as far as this drinking problem you have. But I don't think with what he explained to me, I don't think, and I'm not clinical or anything, that it's really anything to say, hey, you got a drinking problem.
So first of all, I love that Institute of Hope is asking these questions, because that puts you guys way ahead of lots of other people. And again, one of the words that you used that caught my attention was judge. So we're totally, the whole idea of the expert is you're kind of taking judgment out of it. And it sounds like you're doing that, where we're just trying to get some facts, but we're not trying to pass judgment on anybody. What I will say is you're doing the first part of the screening in the Institute of Hope. It sounds like you're doing sort of that one question: how many times in the past year have you had lots of drinks? The part that's missing is the second part, the audit. So, and I've had these conversations with people in the Institute of Hope. What I'd love to see happen is where anybody who's positive for that one question screener gets a chance to fill out the audit, which is the longer screener. And then that's the one that can help you sort of figure out where they are. Because you're absolutely right. You don't know where this guy is in terms of his use. You know that he occasionally has what we would call a heavy drinking day, right? But that doesn't mean he has a use disorder. It doesn't even mean that he has heavy dependence. It could mean that he does what we would call some binge drinking, but that he's not engaging in risky use or true addiction. But the only way to answer that question is to do like the audit. And he can just it would be, I think, a neat idea to have the Institute of Hope do your single questions that you're asking. And then if the patient's positive, send them an audit. And then if the audit was positive, refer them to psychology just to have a conversation. And again, you're not giving anybody labels, you're not passing judgment, you're just sort of saying, this result makes me want to have a conversation with, have you have a conversation with somebody who has some experience on the issue. Does that make sense?
It does. And I also find out that this, speaking of patients, I get more from the patients I speak with than the patients share with their primary care doctor.
Absolutely.
So I feel that it's the need for me to say, hey, I do need to let your primary care doctor know there's some things that I can help you with, but some things is out of my scope of what I can do. So I am going to refer you back to your primary care doctor so they can speak with you and see what additional support they can provide for you. Because I'm not going to say I wouldn't feel uncomfortable talking to them about that, but at the same time, I don't want to overstep my boundaries as far as what I'm providing them with.
I think what you're doing is perfect. Like I said, the only thing that I would hope that that you guys, that your team is connecting people who have an abnormal screen to the audit. And then if that audit is abnormal, connect them to somebody like where you said, where it's in their scope, where they have familiarity and comfort having that addiction discussion. And that can just be one of our many lovely, counselors and social workers at Metro. Because honestly, they'll be better at it than your average physician. Because we don't, I didn't have a ton of training when I was in med school. I learned this, 20 years into my career. So same model for drugs. With the drugs, you just start with a single question like, have you used anything in the past year? And if they say yes, then you're going to do a test, a survey or a questionnaire called the DAST. And then depending on how they score on the DAST, you will either just say, you know, great, okay, good job, you're low risk, or geez, you know, I'm a little concerned about your risk. Let's talk about what that means for your health. Or maybe like, your risk seems higher, and I'd love to set you up with a specialist to talk a little more about ways to sort of stay healthy. Just doing the screening like you're doing in the Institute for Hope without anything else is helpful. So like just doing the screening, it starts that conversation. It allows for a chance to educate people around what are healthy habits. And I try to frame it in terms of health and safety and not talk about, you know, the good or bad or, you know. And it can, just having that discussion like you're doing with a patient can increase their motivation and make them change their behavior. So there's actually been studies that have shown that just doing the screening can produce behavior change and decrease substance use in patients. So there is benefit to just doing the screening, but the idea is that you're taking the screening and then you're attaching it to a conversation in a patient who has sort of a medium or high risk of their use behavior. And it doesn't have to be a big, long, fancy intervention. It can be just a 5-minute talk where you're just sort of exploring what they're doing, how they're using the substance, what role it's playing in their life. And just that brief talk has been also shown to decrease their substance use and increase their functioning, decrease legal outcomes, bad health outcomes. So in your case, Ms. Hardy, that would just mean, you know, you've done the screening and then they're getting connected to somebody like one of our social workers who can have like a brief conversation with them, or a primary care doc who feels comfortable having that 5-minute conversation.
You can call me Pat. I'm fine with that.
Okay, thank you.
You're welcome.
So that gets to the question of how do we talk about addiction? And we went into this a little bit last time. You know, back in the day, we used to lecture people, shake our fingers at people, shame them, argue with them, scold them. And I think any of you that have teenagers can probably vouch for the fact that lecturing doesn't really work. You know, scolding people just makes them feel bad and either just avoid you or hide the behavior. So the newer approach is based on this model of addiction as a chronic kind of brain disease, and it focuses a lot on motivational interviewing. And I'm going to talk a little bit more in detail today about what we mean by motivational interviewing. Again, there's probably people on this call that are experts in it. So please, if you have experience with a motivational interviewing tip or trick that has worked for you, please unmute yourself and share that. I have to say, in my first, 15, 20 years of medicine, I was not good at motivational interviewing. I am learning and I'm getting better, but I would never say that I'm like the expert on motivational interviewing. But the idea with motivational interviewing is that, you know, you're showing respect for the patient, empathy, you're partnering with them, and you're curious. One of my psychiatry friends talks about that. Like, she loves to come at it, the conversation, with a sense of curiosity. Like, what's the role of this in your life? Like, what are your experiences with this substance? What are your goals? So this slide's pretty busy. I think you're going to have a lecture later on with Eileen Seeholzer around motivational interviewing. But it just gets at some of the highlights of what is motivational interviewing. You know, when you do screening on a patient, you know, you do want to ask their permission. Like, can we talk about this, the results of your test? And if the patient says no, that's okay. They can say no, and you can sort of say, well, I'm concerned. I have this information. I'm happy to talk about it when you're ready. And you know, hopefully they'll want to revisit it with you. Like I said, coming at it with a sense of curiosity. What are the patient's experiences? I always like to link their substance use to what they're worried about. So if they're having heartburn, then I'm going to talk about their alcohol, or if they're having, headaches or trouble sleeping, like I'm going to sort of try to link their substance to what they're worried about, what their health issue is. A big part of motivational interviewing is trying to kind of figure out, is the patient ready, and helping them be more ready for making changes, and trying to help give them confidence that they are capable of changes. And it's all about language. So, in terms of efficacy, just saying things like, you're not alone, change is possible, because people, when they're really struggling, they start to feel really hopeless. So, just things can be different is sometimes a really powerful thing to say to a patient. And I'm here to help, like, letting them know that you're there with them, not that you're going to do the work for them, because that's enabling, but that you're there with them to partner with them. And then helping them set a tiny goal, and plan a next step, and kind of being realistic about what are the obstacles to doing that goal. Not setting a huge goal, but something that feels achievable. This is one of my favorite kind of easy go-tos with motivational interviewing. When I'm stuck with a patient, I sometimes will circle back to this. It's just sort of, you're digging into the ambivalence, because when it comes to substances, we talk a lot about, all the bad things around drugs, and don't do drugs. But I mean, the reality is there are pros to using a drug, for patients, or else they wouldn't, people wouldn't use substances, right? It might relax them. It might decrease their stress. It might make them feel more comfortable in a social situation. It might help them unwind after a tough day. So I think being able to have that conversation with patients, like, lots of people use substances, there's good things and bad things, like, can help the patient feel comfortable having that conversation with you, because you're not coming at them with judgment, right? So I'll start with sort of like, what do you like about using blah? What do you like best about it? And they might say, oh, it just, it really relaxes me. And then I will ask them, is there anything you don't like about using this substance? And then they might say, yeah, I have trouble getting up in the morning, or it hurts my stomach. And then you combine those two ideas. So you sort of say, so it does this positive thing, but it also does this negative thing. And the trick is, you end with the negative. And the other trick is, for me, you shut up. You just stop talking, and you just give a pause. And I swear, every single time, the patient will then start talking about why they need to change. So it's just you're acknowledging what's good, you're acknowledging what's bad, and then you're listening. Has anybody ever done something similar to this? For me, it was very helpful when when one of my behavioral health colleagues taught me this. Does anybody else have thoughts about ambivalence, or how they approach ambivalence?
As you stated, I just let the patient speak. Even if I'm in mid-sentence and they say something, I stop and let them say what they want to say. It's because it's more so about them, and not what it is, what I can do for them, but it's what they need to say in order to get the help they need. So if I'm constantly talking to them and not letting them say anything, then they're going to have that feeling, well, here I am, I'm trying to talk to you, I'm trying to get help, but you're not even listening to what I'm saying. So I just, even like I said, even if I'm in mid-sentence or getting ready to say something, I stop what I'm saying and let them say what they need to say.
That's really, really valuable advice. Yeah, people need to feel heard, and you learn a lot. You learn a lot by listening. So the point of this trick, or this tool, is just that you get people not just talking, but you also get them talking about change. Because because that's the whole idea, is you're trying to get somebody who's engaged in risky behavior, heavy use, to consider changing that behavior for their health.
I think too is asking somebody if they have tried to stop drinking or doing the drug, and if they did, what did they do? And what did you like about it? What did you not like about it? You know, just
Right.
trying to find out a little bit more about their use and where they're at, their readiness.
Absolutely. So I'm glad you said readiness, because that's the next slide. But you want to know what worked before, because you want to build on successes. So that's just like positive psychology, like what worked, and let's build on that. In terms of readiness, this is another tool that I was taught by my behavioral colleagues. Scale of 1 to 10. Are you ready to change? Not at all. Are you ready to change today? Being a 10. And then you ask them to say, what's your number? And then when they tell you your number, you ask them, why are you not a lower number? So, okay, you're a 3. Why are you not a 1? So then they start talking about their reasons for being a 3, their reasons for being a higher number. Because again, you're doing all the other stuff that you guys are talking about, which is gathering lots and lots of information and letting a patient get to feel heard. But when you're getting ready to try to encourage change behavior, it's super helpful if the patient talks about the change, not if you're talking about the change. And a way to get the patient to talk about change instead of talking about the glory days of using is to sort of, have these conversations like the readiness ruler, or what's the pro of using, what's the con of using. That kind of sets the way for the patient to talk about what are their reasons, because most patients are ambivalent about their use. That's just really normal if you think about any behavior you do. If you watch too much Netflix, or you don't go to the gym as much as you wish you did, there's reasons why. Why you don't do the behavior you want to do, and why you do wish you could do it. So the idea is to get you to talk more about what you're wishing is possible for your future. So again, this is just sort of another summary slide, just getting at the idea that when you're doing motivational interviewing, you're really trying to build a rapport, collaborate. One of my instructors on motivational interviewing was like, it's the idea is that you're dancing with the patient, you're not wrestling. So you're collaborating with them. And you are listening, but you want your listening to be kind of strategic, so that you're helping kind of support them, and be a resource for them, but also maybe help guide them towards being more open to change. And again, I'm not talking about having this kind of a conversation with anybody who uses anything on any occasion. I'm talking about this conversation, this brief intervention is for your patients who are struggling or having risky use. And then just a quick note, it's when it's your family, when it's your friends, it's much harder to avoid lecturing or enabling. But when we talk about motivational interviewing, it's not the same as enabling, right? It is, you're not trying to protect the patient from negative consequences or make excuses or do things for them. You are trying to sort of honestly just sit with them in their difficult situation, listen to them, support them, and maybe kind of help them figure out how to solve their own problem, if that makes sense. But in the last session, somebody made a comment about how it's different when it's a loved one, and I think that's absolutely true. Like when I found empty bottles of alcohol in my teenager's closet bedroom, like I didn't do motivational interviewing. Like my first instinct was to yell, and eventually I got around to maybe doing some motivational interviewing, but it's hard to to engage in these kind of behaviors when it's a person you love. But this is definitely, these are tools that we try to do at work when we're having conversations with our patients, so that they feel kind of there's a collaboration and you're not judging them, and you're there to listen and support. If you want to do standardized screening at your site, there's great resources. SAMHSA has a whole book about it. You can bill for it. But again, it's a hard thing to do. We've tried it at a few different sites at our hospital. In addition to the screening that they're doing with the Institute of Hope, we've tried the more detailed SBIRT at a couple of our primary care sites, and it's hard for lots of different reasons. So I'm glad to talk more offline about anybody that wants to try to launch more detailed screening and intervention. So does anybody have a case? I have one, but I would, this is somebody my husband saw in a primary care clinic at Metro, but I would love it if you have a case or if you have a question about a patient that we can all as a group sort of talk about. If not, does somebody want to just read through this real quick or out loud? Maybe somebody.
A 65-year-old man with anxiety, depression, HLD-OSA, and remote SUD. Also has chronic neck and back pain from, and what is DJD?
Arthritis, sorry, degenerative disc disease.
Thank you. This gentleman has a remote heroin treatment with methadone from 1995 to 2003, and have sustained since. Admits to purchasing non-prescribed Percocet and Xanax, wants his primary care physician to prescribe narcotics. He's in the PMR clinic, he was offered NSAIDs and physical therapy, and he has a urine tox with fentanyl. It was positive for fentanyl. So the patient with chronic pain and dual diagnosis and substance use disorder and mental illness, how would you approach the conversation, and what treatments would help?
Perfect, thank you. Sorry, I threw in a lot of abbreviations. Quick question, does anybody want to comment on why he has fentanyl in his urine? What their best guess would be?
It's in the Percocet or the Xanax.
Right, it's not Percocet, it's not Xanax, it's just pressed fentanyl. So, and we mentioned that last time. I used to actually see people who bought, OxyContin off the street, and it was OxyContin in their urine. Nowadays, when my patients tell me they're buying OxyContin, they're buying Adderall, they're buying Xanax, Percocets, it's almost always nothing but fentanyl in their urine. So that's that'll be talk number 4 in terms of, fentanyl test strips and harm reduction. But yeah, so this guy probably was being honest that he's been buying what he thinks is Percocet and Xanax, but for his anxiety and for his neck pain, but it's pressed fentanyl. So how would you approach the conversation? Like you have somebody who probably has like a moderate use disorder in the moment. In the past, maybe he had a more severe use disorder. And he's also got, anxiety and depression and chronic pain in his neck. It's real, so how would you guys approach the conversation?
I personally think just trying to get him to open up as much as possible. So I wouldn't just jump right into asking him, so why are you using all this? Just find out, hey, how's your day? What's going on? What's new? Seen any, just general conversation with him. And then if he opens up and says something about it, that's when I will say, well, why did you decide to do that? Or why? What's going on that made you feel that way that you need to do that? Just steer the conversation away from the problem in hopes that he will bring the conversation to the problem. So that's how I would approach it.
I think
Sorry, go ahead.
the way I'd be approaching this is it sounds like he is not currently prescribed medication for his chronic pain condition and is attempting to source medication to manage that pain condition outside of a medical facility. So he's admitted to trying to source Percocet and Xanax. Let's try and set him up with a medically managed pain care program. There's a ton of different options because it sounds like if we can get him medically managed, he won't have a reason to buy non-prescribed medications, which would eliminate the risk from the fentanyl. It doesn't sound like a significant substance abuse issue. It sounds like he's trying to manage a chronic disease that's not being managed.
Right. And that can be hard to tease out, like what's addiction versus what's, a medical illness and what's both, which is kind of why I threw this case out, put this case out there. But I think you're absolutely right. You need to validate he's got pain and you want to treat his pain. But probably chronic narcotics is not full agonist narcotics, meaning like Percocet is probably not the way to go. But I like the idea of validating. I also like what Pat said about develop a rapport. And maybe, instead of the why questions, I also like at one point, Pat, you were talking about sort of like using a what question, because sometimes why can make people defensive, like, why are you doing this? As opposed to like, tell me what's going on. Other thoughts about how you'd approach the conversation?
I think I would let him also know that his urine was positive for fentanyl, because more than likely he doesn't realize that he purchasing the drugs off the street are dangerous, and let him know. And I agree with, I think was Maggie that said, let's talk about a pain management program that we can get you in to help you manage that pain rather than have to turn to the street drugs that you're getting, fentanyl and not what you think you're getting.
Absolutely. I've had so many patients over the past few years, especially where they had no idea there was fentanyl in their urine. They were shocked, they were upset. So it gives you an opportunity to give them some Narcan, to give them some fentanyl test strips, to educate them that, the supply on the streets is not what it used to be. So really, I mean, when I talk about the conversation, it's mostly all that stuff that the motivational interviewing, the brief intervention, right? Just sort of partnering with them, being curious, finding out what their goals are. And in this particular case, validating he's got an illness and there's good treatment out there. So I've heard people talk about pain clinic, which I think is a great idea. Any other thoughts about what they would do? What folks would offer?
If he's not already seeing behavioral health specialist because he does have a dual diagnosis, getting him in with a behavioral health would probably be beneficial. If nothing else, keeping the mental illness managed will make it less likely that he relapses or exacerbates his use of substances.
Yep. Absolutely. So getting him some mental health medications and mental health expertise is a great idea. Having a level of care assessment. Have you guys, I'm assuming you guys are familiar with that, where you have sort of an hour, you sit down with a counselor and do an intake and just sort of try to figure out, what is my level of addiction and what kind of treatment, behavioral treatment might be helpful. So doing like a mental health assessment, a level of care, getting him on an SSRI, like a, Zoloft or something. And then, in his particular case, since there probably is an aspect of addiction going on with him, is, getting him maybe some peer support, people with lived experience that can kind of, whether that's AA or NA or Thrive or, but having somebody who can offer him some lived experience. And then the last thing I was going to throw out there is MOUD, so getting him the opportunity to consider buprenorphine for his pain. And we'll talk more about that next week, the different medications for substance use disorder. But buprenorphine can be not only a great way to help him avoid going back to, high level addiction, but it can also be a way to help relieve his pain. So it's kind of killing two birds with one stone. If you divide the buprenorphine, it's going to help him not relapse into severe addiction. And it's also because of his pain. And it's also going to help him relieve his pain because it's a partial agonist. So it has a partial opiate effect. So those would be my thoughts. And that's kind of what we ended up doing. My husband ended up doing with him was just, got him connected to counselors. And honestly, he was in an IOP, and then aftercare, they got him a peer support worker. We got him, my husband got him, well, I'm saying we, because my husband saw him and then I saw him and then he went back to my husband once he was sort of a little bit more stable. We got him on some Suboxone, divided doses for his pain, and we got him on some Zoloft, and he did really well. So coming at it from lots of different angles. And, he did also see the pain clinic to talk about injections and other options for treatment in addition, beyond NSAIDs and physical therapy. So I want to be mindful of time. Just anybody have any other final thoughts on this case? If not.
If I could,
Yeah.
just by his age, everything that everyone said was great. I think the order in which things are done also makes a difference, but yes, we're talking about his mental health. Yes, we're talking about substance abuse, but finding a good community-based organization to where if we as professionals aren't available, that he can rely on having his back pocket, having his phone, just in case things were to happen. I think him having that resource as well is also helpful. And that, with him being 65 years old, maybe he's interested in getting into some physical activities or things in his neighborhood. And I feel like both of those previous conditions or affects would be affected by him having that community-based support as well.
I love that. Yeah, absolutely. With our seniors, we need to be thinking about ways to keep them in the game, keeping them active physically, keeping them from being lonely. And that can go a long way in terms of both their physical and their mental health. So we have a quiz, which I'm going to skip over for 1 sec. There are the slides, which you'll be getting. The slide deck has resources attached to it about how you can find out who, if you don't already know, who in my county can offer addiction treatment services. This is, a link to find those resources if you don't already know them. These are other useful resources that I find constantly turning to in my patients in recovery. And then these are overdose prevention resources, which we'll talk a lot more about in the 4th and final session. And then this is the QR code. I'm going to let you talk, Darian.
Yep, thank you. So I did put that link and the QR code also in the chat. But if this is easier for you and larger, please just make sure you complete this just to receive your credit. I will email everyone on the call today with the slides, and also again these links, and then the link for the registration for the following 2 sessions.
Next week.
Yep, and any question, same time next week, any questions for me, please go ahead and message me or email me.
And I put my email up there. Please, if you have a case, send me it. I'd love to do one of your cases instead of one of mine. Next week, we're going to talk about treatment. And by treatment, I mean both medication and behavioral treatment and also peer support options. And this is the quiz. If people want, we can take a moment and do it. Or you can, I don't know. Is it useful to go through these together? Does somebody want to do number 1?
Substance use is a spectrum that ranges from non-harmful use to addiction.
True, false?
True.
Yep. Number 2.
Substance use disorders are rare.
True, false?
We have some falses in the chat.
Yep, false. So about 10% of people have substance use disorder. And if you get into clinical settings, that number's even higher. There's no good treatment for substance use disorder.
False as well.
Right. We have great medicines and great behavioral treatment and also great sort of peer support. Number 4. Somebody want to read?
Most
patients.
patients, oh, go ahead.
Oh, sorry. Most patients with SUD are identified and connected to treatment. False.
Yeah, only about 1 in 10 people get connected to treatment. And again, there's disparities in terms of who gets connected. Number 5.
Is that expert is an evidence-based method of universal screening and intervention that can decrease the amount of substances used and the associated complications. True.
Yes, ma'am. And number 5, early intervention in.
Oh, sorry.
That's okay. This is a wordy slide. Early intervention in risky substance use can prevent progression. True, false?
True.
You got it. Anybody want to do 7?
The first step of expert is referring a patient to treatment. True.
That's false.
Screening.
It's false. Yeah. So the S is screening. So
I knew that. I just wanted to see what y'all was gonna say.
you got me. Perfect. Number 8.
The foundation of a brief intervention is using motivational interviewing tools. True.
You got it. Yeah. Empathy, partnership, change talk,
And listening, of course.
listening. Thank you. Last one.
Your county's alcohol, drug addiction and mental health board is a good resource for local addiction treatment programs. That is true.
Yep. Sam says another good resource, and I hope anybody that has other ideas, please throw them in the chat.